from all over the world, all CEC fans and audience. Tonight we have a very special and a very scientific, actually interesting meeting. We will be discussing the series of the European Society of Cardiology 2020 updates and guidelines. Tonight we will be discussing the atrial fibrillation section of those guidelines in the form of case-based discussions. Tonight we have a very eminent speakers and audience and friends of my own. We have Dr. Ahmad Ammar. He is a PhD from Ain Shams University and lecturer of cardiology, and he is MRCP qualified and he's consultant of cardiology at Worcestershire Acute Hospitals NHS Trust in United Kingdom. Dr. Ahmed will discuss with us the introduction to atrial fibrillation, the definition, how to diagnose, and the ABC pathways, what is new in the 2020 guidelines. And then Dr. Ahmed will give us a very interesting interactive case-based discussion. The second half of the webinar will be discussing the different ABC pathways in several clinical scenarios, and this will be also presented by my dear friend and brother, Dr. Sharif Al-Touhi, PhD, lecturer of cardiology at Ain Shams University, and also MRCP candidate, and he is consultant electrophysiologist at Saudi German hospitals in Egypt. I'm very happy, I'm very interested and eager to learn tonight a new updates from the guidelines. I will not make it longer, and I will pass the mic to my dear friend, Dr. Ahmad Ammar. So Ahmad, you may start sharing your screen.
Thanks a lot, Dr. Snahan, for this invitation. Good evening, everyone. So good evening, everyone. I'm Ahmad Ammar, one of the consultant cardiologists at Worcester Royal Hospital. We will be discussing in brief today the latest updates in the ESC guidelines for atrial fibrillation, which was published a few weeks ago. And I'll discuss briefly the first three topics from these guidelines, which include the definition and diagnosis of atrial fibrillation, and the screening for atrial fibrillation, and the new ABC pathway for the integrated management of patients with atrial fibrillation. And the guidelines has highlighted the importance of having a very clear definitions and diagnosis for atrial fibrillation. And as all of us know, the very famous definition for atrial fibrillation, which depends on the ECG characteristics, which include having irregular RR intervals, except in complete heart block, of course, and absence of distinct repeating P waves and irregular atrial activations. And one of the most important definitions is regarding the clinical atrial fibrillation. So how to diagnose clinical atrial fibrillation? So clinical atrial fibrillation is having symptomatic or asymptomatic atrial fibrillation that is documented by 12-lead ECG. And the minimum duration of an ECG tracing required to establish diagnosis of clinical AF is at least 30 seconds in a single-leaded ECG, like in Holter ECG, or to have a very clear 12-leaded ECG. Otherwise, you don't have the diagnosis of or documented diagnosis of clinical atrial fibrillation, and you should not start medical treatment for atrial fibrillation. The other important topic is regarding the atrial high rate episodes and subclinical AF, which is very, very important and very hot topic these days regarding whether to treat the atrial high rate episodes like the clinical AF regarding anticoagulation rate and rhythm control strategy, or this is not, or the atrial high rate episodes are not clinically relevant. And simply the definition for atrial high rate episodes and subclinical atrial fibrillation, it refers to individual patients without any symptoms. However, they have, for example, a pacemaker with atrial rate, and atrial high rate episodes has been detected by the device. So should we anticoagulate these patients or not? This is a very important question. The other topic, which is, or the other definition for subclinical atrial fibrillation, which is a little bit broader, it includes the atrial high rate episodes confirmed for atrial fibrillation, atrial flutter, or and atrial tachycardia. And also it includes episodes detected by insertable cardiac monitor like the loop recorder or other devices. And if we look through this flow chart, which it speaks about, or it includes how we detect atrial fibrillation. So for example, if you have a 12-lead ECG or an ECG strip, then the diagnosis of clinical AF is established, and then we can manage accordingly. However, if, for example, if you have a patient without any symptoms and he has had a pacemaker for complete heart block, and then atrial high rate episodes has been detected, or he has had a loop recorder for palpitations and short episodes has been detected, shall we anticoagulate these patients or not? This is the most important question. And looking through the observational studies, we will find that a very high proportion of patients with atrial high rate episodes, with very short episodes, later on when we keep close following up them, we find that there's transition to longer episodes and then to established clinical atrial fibrillation. And looking at the stroke rates for these patients, again, when we have an atrial high rate episode, short episodes less than 5 minutes, the risk of stroke is usually very, very low. However, having longer episodes up to 24 hours, the risks increase markedly. And what we know from the data, available data, that very short episodes are considered clinically irrelevant, and having longer episodes, minimum of 5 minutes, these episodes are associated with increased risk of clinical atrial fibrillation. However, the absolute risk of stroke associated with atrial rate episodes mostly is lower than with clinical atrial fibrillation. And that's why randomized controlled trials are needed to establish the benefit from anticoagulating these patients. And this is the proposed management of atrial high rate episode based on the ESC guidelines. And because of the lack of strong evidence, there is no specific recommendation from the ESC guidelines committee. However, as we see here, if you have a patient with long episodes more than 24 hours, or patients with a high Shadvask score of 2 or more in males and 3 or more in females, at that time, we should consider anticoagulation. So consideration of anticoagulation should be considered at high and very high risk of stroke patients. So patient with previous stroke, patient above 75, patient with Shadvask score of 2 or more in male or 3 or more in female, you should consider anticoagulation in these patients. For patients with atrial high rate episodes of 5 minutes up to 24 hours, in these patients, they need a very close follow-up. And in case we find that the risk of stroke is increasing or the burden is increasing, anticoagulation again should be considered. Patient with low risk of low Shadvask score or very short episodes, at that time, we should consider that as innocent bystander and there is no need for anticoagulation. And then we'll come to the screening for atrial fibrillation. And again, I don't think there's a marked change in the guidelines regarding the screening. However, I would just want to highlight 2 important things. First of all, one of the things that we need to consider is always to get the patient involved in the screening process. So the patient needs to be involved. The patient needs to be informed about the significance and the treatment implication of detecting EF. The other things that diagnosis should be always established after physician review of either 12-lead ECG or single-lead ECG recording of 30 seconds or more. Because we see sometimes in our clinical practice that some people, especially if someone is not specialized in cardiology, he established diagnosis of atrial fibrillation based on symptom and start anticoagulation based on that. And this should not be the case. Documentation of atrial fibrillation should be established first before establishing the diagnosis. And this is just the systems used for AF screening. And nowadays with the technology, there are a lot of different systems, especially in the COVID era. Sometimes it's very difficult to get 12-lead ECG. So there is the loop recorder, which is very commonly used in most of the countries. There is now the Alive Core device, which is just a very small device with a sensor connected to the smartphone. And then you can get a very nice recording to document atrial fibrillation if needed. And what's important about the classification of atrial fibrillation, I know that most of us are aware about the classification. However, it's very important that the old terminology of valvular and non-valvular atrial fibrillation and chronic AF, this should be abandoned and should not be used in clinical practice. First of all, it's very confusing using the term valvular and non-valvular atrial fibrillation. So 5 years ago, when we say valvular atrial fibrillation, the first thing to come in mind is any patient with valvular heart disease. However, now with the latest guidelines and more evidence we are having about the use of CHA2DS2-VASc score in patients with mild valvular heart disease, so we know that moderate to severe mitral stenosis and those with mechanical prosthetic heart valves are the only two entities excluded from the CHA2DS2-VASc scoring. However, for example, if I have a patient with mild mitral regurgitation, mild mitral stenosis, this is not an indication for anticoagulation. And other things about chronic atrial fibrillation, again, it's confusing, and it's better always to try to classify your patient based on the temporal pattern of atrial fibrillation. Is it first diagnosed? Is it paroxysmal? Is it persistent? Is it long-standing, persistent, or even if it is permanent? And then we'll come next to the most important and updating the guidelines, which is about the integrated management and the APC pathway. And again, the guidelines highlights the importance of shared decision about specific AF treatment options. It's recommended that the physician should always involve the patient in the decision making, to be involved in decision making, and to be informed about the advantage and disadvantage of different treatment options. And this is just an image to highlight the importance of getting the patient centered in the management of atrial fibrillation. So all of us concentrate on the stroke prevention, rate, risk, and management of risk factors, but there are a lot of things, a lot of other things that we need to know about. So it is multidisciplinary approach rather than one-man show. So it is not only the cardiologist who should be involved in the management of atrial fibrillation. Sometimes you need help from dietitian to get weight loss, which is very important for obesity, and also to increase the success rate for AF ablation in morbidly obese patients. Psychologists is sometimes needed, and other team members. So it's always very important to get the different teams involved in the AF management. This is the old famous 5-domain-based AF management protocol as per the ESC guidelines published in 2016, and this has been replaced by the new nice and simple CEC to APC approach. So this is very important slide regarding the AF management, and I would advise everyone, when you see a patient with atrial fibrillation, just to try to be very systematic and to go through the different steps in the AF management. And if you go through these different steps, I'm sure that the patient will be properly managed. So the first step is confirming the diagnosis, as we said. And the first thing to do is to have a 12-lead ECG, or to have a rhythm strip at least of 30 seconds showing AF pattern. At that time, you have a confirmed diagnosis of atrial fibrillation. And this is a class 1 indication, as we mentioned before. The second step is regarding the characterization of atrial fibrillation, the 4S AF scheme. And this is very important, which is a step which includes the characterization of atrial fibrillation. So if you have a patient with atrial fibrillation, and then you confirmed your diagnosis, so before starting the medical treatment, you need to know certain important things. First of all, what's the risk of stroke, which is very important. Secondly, what is the risk for, or what are the symptoms the patient is having? And it's very important to know whether the patient is having mild, moderate, or severe symptoms, and this will have its implication on the management protocol. And then the severity of AF burden, whether the patient is having paroxysmal or persistent or permanent atrial fibrillation. And the latest, or the fourth step, is substrate severity, and this includes proper assessment for comorbidities and risk factors and the atrial cardiomyopathy. And again, the structured characterization of atrial fibrillation is very important, and it's class 2A. I'm not going to go through the CHA2DS2-VASc score. I think most of us know about it. I just want to highlight a very simple thing, which is the congestive heart failure. Some of us get confused when we mention congestive heart failure, and the first thing to come in mind is patient having heart failure symptoms. So heart failure symptoms is considered a risk factor, and this should be counted as 1 point, but patient without any symptoms, but just having LV impairment, moderate to severe, so if the ejection fraction is less than 50%, this should be considered as one of the risk factors, and this is very important. The other points, I think most of us are aware about it. And again, this is the famous symptom scale. And as we mentioned, we need to know what type of symptom the patient is having and what is the severity. And for example, if you have a patient without any symptoms, there's no need or there is no indication for AF ablation. If you have a patient with severe symptoms, you need to intervene, and you cannot just keep the patient without proper control strategy. The other thing that is very important is regarding the burden. So when we mention the AF burden, simply it is determined by the AF temporal pattern. For example, if you have a patient with paroxysmal atrial fibrillation, the burden is definitely less than patient with persistent atrial fibrillation. And to get an accurate estimation of the burden, this is usually done by intermittent ECG monitoring. Patient having devices will get better or accurate estimation of the burden through the device. And the implication of that is that clinical AF burden might influence the response to rhythm control therapy. So for example, patient with paroxysmal atrial fibrillation, the success rate from AF ablation is much higher than patient with persistent atrial fibrillation. And this is very important question. I mean, the patients are always asked before, after offering AF ablation procedure, what is the success rate? So if you mention success rate for persistent atrial fibrillation, in between 50 and 60%, it's completely different from 80% at least in patients with paroxysmal atrial fibrillation. And then next is the substrate evaluation, and this includes other comorbidities. So for example, in patients with ischemic heart disease, we need to probably assess the risk for or the ischemic heart disease and whether the patient needs medical treatment for that or he will need an intervention. This is a very important step in the management of atrial fibrillation. And then the other topic, which is the atrial cardiomyopathy, involving the fibrosis and the remodeling process which occurs in the atrium. And this is still under investigation. We don't have a clear recommendation about that, but this diagnostic workup is very important. Here in all AF patients, we need to be very systematic. We need to get proper history, 12-lead ECG, and to get blood tests and transthoracic echocardiography. And this is very important for the characterization of the patients. And then in selected AF patients with different substrates, for example, patients with severe valvular heart disease and patients with coronary artery disease or patients with other problems, in these patients, we might need to do more investigations like transesophageal echo, coronary CTA, or even we might need to do 24-hour tape to look at the rate control if the patient is not adequately controlled by medical treatment. This slide is just to highlight the importance of substrate evaluation. So it's not only about treatment of atrial fibrillation. So patients with severe mitral stenosis and atrial fibrillation is completely different from patients with paroxysmal atrial fibrillation with normal heart. So we always need to understand that. And this is a very hot topic. And these days there are a lot of studies about, for example, role of cardiac MRI in substrate evaluation before AF ablation procedure. So for example, patients with persistent atrial fibrillation, we might expect to have more scarring and more fibrosis rather than patients with paroxysmal atrial fibrillation. And then we'll come to the next step, which most of us just go directly to this step, which is the treatment. And the first thing to do is the anticoagulation. And there are three important steps. First step is to identify your low-risk patients, like patients with shared VASC score 0, and then to offer anticoagulation for patients who are having shared VASC score of 1 or more. This is the famous shared VASC score, and this is the Haspled score, which all of us know. And I just want to highlight important thing about this slide. We always concentrate about the risks of stroke and risk of bleeding, but there are potentially modifiable and modifiable risk factors for bleeding, which is very, very important. and we need always to address these points. For example, if you have a patient with a high blood pressure, uncontrolled, excessive alcohol intake, not adherence or anticoagulant, or the bridging therapy is happening, all of these risk factors, if well controlled, the risk of bleeding will decrease markedly, and this might prevent further bleeding episodes, and this might be of a very important in patients with high HAS-BLED score. So it's very important to address the modifiable risk factors and try to keep it controlled. This is the same TT2R2 mentioned by the guidelines. This is not something new, but it would be important to know when to switch patients from vitamin K antagonists to NOACs. So all of us know that NOACs is now class 1 recommendation and it's preferred over the vitamin K antagonist. However, certain patients are being kept on vitamin K antagonist. So which patients we should try to avoid vitamin K antagonists or to switch them to NOACs? This should be based on certain risk factors, and this is addressed in this risk scoring, including the age and the female and the comorbidities and the interacting drugs, and because all of us know that warfarin is interacting with a lot of drugs and even the race. This is a dose selection. Again, there's nothing new about the dose selection, and some of us might know about the elder care, the new trial about using ovidoxaban 15 milligram in elderly patients and the decreased bleeding events with that. And again, this is a nice flow chart just to address the steps. First step, to identify the low risk patients, and then you exclude them from anticoagulation, and then you should start anticoagulating patients with SHAD-VASc score 1 or more, 2 or more after calculating the HAS-BLED score, and as we mentioned, address modifiable bleeding risk factors. This is class 2A for patients with risk factor 1 for male or 2 for female. For SHAD-VASc, more than that, 2 for male or 3 for female. This is class 1 recommendation. This is just to changes in the new guidelines. So in patients with VKA, switching to NOACs is recommended. It's class 1. So if you have a patient on vitamin K antagonist with low time in INR therapeutic range, you should think about switching to NOACs very early. The other important things regarding the risk reassessment. So when we assess the risk for stroke for a patient, for example, 40 years, 30 years with atrial fibrillation, it should not be just one step. So you need to reassess later on, because the patient might develop other risk factors, or the patient, for example, might develop tachycardia-induced cardiomyopathy, other risk factors, and at that time, anticoagulation might need to be considered. So you should, first of all, do the baseline risk assessment, including bleeding and stroke risk assessment, and you should repeat that in 4 to 6 months in patients at low risk. Again, estimating the bleeding risk does not mean that these patients should not have anticoagulation. So if you have a patient who has HAS-BLED score of 3 or more, that doesn't mean that this patient should not have anticoagulation. It just means that the patient needs closer follow-up. However, if the patient is having absolute contraindication, at that time, anticoagulation should not be offered. One last thing is regarding the clinical pattern of atrial fibrillation. And so if you have a first detected paroxysmal persistent atrial fibrillation, this won't make any difference regarding the indication for anticoagulation. So patient having paroxysmal atrial fibrillation is not different from long-standing persistent. I know that there are some data about the risk of stroke, and that the risk of stroke is higher when you have a persistent or long-standing persistent, but we don't have a clear evidence saying that the patients with paroxysmal atrial fibrillation should not be anticoagulated. So the risk might be higher, but this does not indicate that we might omit the anticoagulation with patient with low AF burden.
So Ahmed, because this is very interesting, I know the next part is a very important part, and I have maybe like 3 questions from the YouTube. So let me pass those questions to you quickly, and all of them are mostly about the high-risk episodes. So we have 2 questions from Hadar Mustafa. She's asking you first, during the follow-up visits for every patient with a pacemaker, should you assess the high-risk episodes for any patient with pacemaker, and should you assess the SHAD-VASc score in every visit during the pacemaker programming to follow up and determine the risk of development of AF and the need for anticoagulation? This
Yeah,
is the
this is
first
very
question.
Yeah, this is very important question. I think that the high rate episodes are usually automatically recorded by the device, and you get a burden. It's very clear. And you, for example, during every device check, definitely I would recommend that when we do the device check, you should have a look. For example, patient having atrial high rate episodes, what is the duration and how many episodes did the patient have, and you need to document that. And this is very important because sometimes patients, as we mentioned, patients are having very short episodes, which is not clinically relevant, but with time, the episodes might increase in duration, and at that time, the patient might be at risk of stroke. And definitely, if the patient having atrial high rate episodes, it's important to calculate the CHAD-VASc score. And as I mentioned, if the CHAD-VASc score is very high, 3 or above, at that time, we might consider anticoagulation even with relatively shorter episodes. We don't have a very clear data about cutoff values, but we have some observational studies that the atrial high rate episode, the risk of stroke increases with very high CHAD-VASc score.
So Hagar is asking you, you may consider that the high risk to the high rate episodes are considered as subclinical atrial fibrillation.
So simply the atrial high rate episodes is just a part of subclinical atrial fibrillation. So subclinical atrial fibrillation means patients are having atrial fibrillation without symptoms and without documented ECG. So this can be detected either by a loop recorder or by a pacemaker. If it's detected by the pacemaker, this is called atrial high rate episodes.
So Nes Fatri is asking you also about the atrial high risk episodes diagnosed by surface ECG or external monitors with a heart rate less than 175. Is this real atrial high rate episodes, and does this need anticoagulation or not?
So if you have a documented 12 lead ECG, this is now classified as clinical atrial fibrillation. So this will need an anticoagulation regardless of the rate. So atrial high rate episodes, the definition of atrial high rate episodes is episodes without symptoms and without documentation. So you don't have a 12 lead ECG or a 30 seconds rhythm strip. But if you have either of these, this will transfer you to another entity, which is the clinical atrial fibrillation. And if you have a clinical atrial fibrillation, definitely you will anticoagulate according to CHAD-VASc score.
So Ahmed, I have a question, and I know this is a gray zone. You mentioned that the first detected episode of atrial fibrillation is not a contraindication or should not prohibit us from anticoagulate the patient. So we all know that, especially in elderly, we are confused detecting that this patient has an AF for even a short time. This AF is the first episode or the first detected episode. So what's your management? Do you consider that this patient is a high-risk patient, especially if this patient is elderly or having an ischemic heart disease, and entering them into the cascade of anticoagulation or the risk stratification for anticoagulation or not? What's your management in this vague entity of patients, the patient that you detect the AF for the first time without any clinical indication or clinical symptoms of palpitation?
Yeah, I mean, patients who are having a first detected atrial fibrillation, patient, for example, he has had an ECG done routinely, and then we found that the patient is having atrial fibrillation, and this was just paroxysmal or one episode. We know that the risk of stroke is related to the burden. So if the patient is having AF all the time, the risk is higher. But what the guidelines want to say is that even if the patient has had only one episode, or even if it is first detected, there's still a risk of stroke. And that's why we need to assess bleeding risk and the stroke risk and anticoagulate accordingly. In elderly, it's a little bit challenging because, as you said, it's very complex. Patients are having very high bleeding and very high stroke risk. So you usually need to make a balance, but definitely the anticoagulation should be considered. And that's why we said that the clinical pattern of atrial fibrillation, whether it's first detected, paroxysmal, permanent, persistent, this should not change the management plan regarding anticoagulation. Although, as I said, there is a difference in between these types regarding the risk of stroke.
Okay, thank you, Ahmed. You may continue.
Yeah, definitely. Yeah, thank you. We have finished with the anticoagulation, and the next step is regarding the symptom control, which is very important. And I think the guidelines address the symptom control strategy in a very nice way. And there are three important points to be considered. First point is regarding assessing the symptoms, quality of life, and patient's preferences. Second is regarding the rate control. And third point is regarding the rhythm strategy. And rate control therapy, it's very important to know when to go just with rate control therapy. So there are four main indications for rate control therapy. First of all, background therapy in all AF patients. So if you have a patient with diagnosed atrial fibrillation, regardless of the further management plan, he needs to be on a rate control so as to control his symptoms. And then for even if it is paroxysmal, when he develops atrial fibrillation, it would be better to have an atrial fibrillation at rate of 100 rather than 180. And the second things regarding first choice therapy in patients with no symptoms. It's very commonly to see elderly patients, as we mentioned before, without any symptoms and having atrial fibrillation being diagnosed. And at that time, there is no indication for rhythm control strategy. Third point is regarding patients being treated as permanent atrial fibrillation after failure of rhythm control. And the fourth point is patients when risks restoring sinus rhythm outweigh the benefits, and we'll go through this point later on. The guidelines recommend lenient rate control in all the patients. This is a gold standard, so rate less than 110 is acceptable, except in certain patients, and these patients include patients with CRT to allow biventricular pacing and to allow the patient to get the benefit of biventricular pacing. So you need to get the heart rate well controlled, even less than 80, to be able to biv pacing the heart. And in certain patients, for example, patients are having ischemic heart disease, or in certain patients like patients with heart failure. So in these patients, we might need to consider lower rate rather than the lenient rate control. And if we go through the choice of rate control drugs, there is no much to add about that. It's almost the same like the previous guidelines. But what I just want to add is that we always assess the comorbidities, and this is the importance of proper characterization at the beginning. So if you characterize your patient at the beginning, you'll know whether your patient are having COPD or asthma, you'll know whether the patient are having accessory pathway, you know whether the patient is having heart failure or hypertension. At that time, you can choose probably which rate controlling drug you should go for. For example, patient with hypertension, you might go with beta blockers or non-dihydropyridine first. Patient with COPD will try to avoid beta blockers. Patient with pre-excited AF, you will go for ablation from the beginning. And I want just to highlight here one thing regarding the digoxin. So one of the things that has been raised over the last few years regarding digoxin is the mortality associated with digoxin. So there has been some observation studies stating that digoxin is associated with higher mortality, and we should avoid digoxin in management of atrial fibrillation. And this is a very nice prospective study presented in the latest ESC, and it compared digoxin to bisoprolol or the beta blockers in a patient with heart failure symptoms and permanent atrial fibrillation. And interestingly, the digoxin has had a similar effect on heart rate and physical component compared to beta blockers. So you get same quality of life, same heart rate control with less adverse effects with digoxin. So this has not been addressed in the latest guidelines, but it's very important because, as I mentioned, most of the observational studies mentioning that digoxin is associated with mortality, higher mortality, was a little bit biased because digoxin was given for very sick patients. So digoxin should always be considered. It's not the first line as recommended by the guidelines, but it's usually very helpful, especially in patients with heart failure. And as we mentioned here, the lenient rate control is class 2A, and you should always look at the comorbidities, which will guide your choice of the rate controlling drugs. Secondly will be the rhythm control strategy. And it's very nice that the guidelines address one of the things that we commonly see in our clinical practice is regarding the symptoms. So the rhythm control strategy is based on the symptoms. So if you have a patient not having any symptoms at all, he should not, or the patient should not be offered the rhythm control strategy except in certain types, and we'll go through that later on. But what I want to highlight is regarding the unconscious adaptation to reduce physical activity. And to make it very simple, we see, for example, elderly patient, 70 years old, and when you ask the patient, do you have any symptoms? He will say no, he will deny having any symptoms. And then when you ask him what you can do and what you cannot do, he might say, I can walk for 10 minutes. And I think that I cannot walk more than that because of my age, I'm above 70. And then when you cardiovert this patient back to normal sinus, he might say, okay, now I can walk for 30 minutes and he will feel much better. So sometimes the patients misinterpret the symptoms and they have some sort of unconscious adaptation to reduce physical activity. And that's why sometimes we, as a cardiologist, should have a low threshold to cardiovert patients, and then we can reassess the symptoms. So one of the things, if you're not sure about the symptoms in patients with atrial fibrillation, you can cardiovert, reassess the symptoms. And for example, if the patient said, I could not feel any difference in AF and in sinus, that means that he doesn't have any symptoms. And if the patient felt a difference, so the symptoms was a little bit not very clear, or there was some sort of unconscious adaptation. If the patient does have symptoms, we need to be sure that this is related to atrial fibrillation, and then we need to look at the risk factors favoring rhythm control. So if you have a younger age, or first episode or short history, tachycardia-induced cardiomyopathy, normal or moderately dilated left atrium, and no marked comorbidities or heart disease, or AF precipitated by temporary event, these risk factors or these factors should favor rhythm control strategy. So patient with structurally normal heart is completely different from patient with severe mitral stenosis regarding the rhythm control strategy. So we need always to look at the factors favoring rhythm control and factors which indicate that the rhythm control strategy won't work. So having massively dilated left atrium, for example, indicates that the patient won't maintain sinus rhythm regardless of the rhythm control strategy. And next is the cardioversion. And again, there was a lot of updates in the cardioversion. And this is a very important thing because most of us are doing cardioversion procedures on daily basis. And one of the things that we need to mention here is that regarding the cardioversion is regarding the anticoagulation. So in hemodynamically unstable patients, definitely we'll go for DC cardioversion, and then we will anticoagulate for 4 weeks post-cardioversion. And then the long-term anticoagulation will be depending on the SHAD-VASc score. However, if you have a patient with hemodynamically stable atrial fibrillation, should you cardiovert, or we can just wait? This is very important things that has been addressed in this guideline. And there's a new term, it's not a new term, but it's the first time to be mentioned in the guidelines. It's regarding the delayed cardioversion. So what we know from the studies that up to 80% of the patients with paroxysmal atrial fibrillation, the patients return back to normal sinus rhythm within 24 to 48 hours spontaneously. So in these patients with atrial fibrillation of less than 12 hours, with no marked comorbidities, low SHAD-VASc score, delayed cardioversion is very, very wise decision and might be considered. So we don't have to rush to cardiovert every patient with atrial fibrillation, especially if the patient is hemodynamically stable. So for example, if you have a patient with atrial fibrillation rate of 140 beats per minute and not markedly symptomatic, you can keep monitoring for 24 hours. And in most of the cases, the patient will be spontaneous normal sinus rhythm will be restored without any further intervention. Electrical cardioversion might be considered, and it's usually for hemodynamic unstable patients or for patients more than 48 hours if the risk, if the onset is unknown. And again, it's very important to look at the anticoagulation, be sure that your patient was anticoagulated if you're going to cardiovert, if the atrial fibrillation onset is more than 48 hours. As we know that NOACs should be the first line of treatment regarding anticoagulation, and it's class 1. This is a very new recommendation. So in patients with definite duration, patient with atrial fibrillation of less than 24 hours and very low stroke risk, do we need to anticoagulate these patients post-cardioversion or not? And according to the guidelines, it's now class 2B that the 4 weeks of anticoagulation post-cardioversion may be omitted. And this is based on observational studies suggesting that the risk of stroke in these patients is very, very minimal. And we don't have randomized controlled trials to evaluate anticoagulation versus no anticoagulation in these patients. So that's why it's class 2B, but it's very important to consider not to anticoagulate patients if they have a very low shared vascular score and they don't have atrial fibrillation for more than 24 hours. So less than 24 hours, shared vascular score of 0, you can discharge a patient without anticoagulation. However, this is class 2B, and this should be individualized. It should not be as a routine, as we mentioned, because there's no randomized control trials evaluating that. The pharmacological cardioversion, I'm not going to add a lot about the pharmacological cardioversion. The only things that I would mention is regarding patient with sick sinus or AV conduction disturbance or prolonged QTC. These 3 disorders, we should avoid pharmacological cardioversion in these patients because of the risk of proarrhythmia. So it's very important before considering pharmacological cardioversion to properly assess your patients to be sure that he does not have any other heart rhythm problems. And then we'll go to the next hot topic, which is atrial fibrillation ablation. And the symptom improvement, which has been confirmed in the interesting large CAPANA trial, has had implications on these guidelines. And although we don't have a clear evidence or randomized controlled trials stating that reduction in mortality, stroke, and major bleeding with atrial fibrillation in the general population, but we still have trial and other trials. So I'm going just to go quickly through the East Affinet trial. This trial has been presented in the late ESC, and again, it was not including the guidelines, but it's very important and it might be a game changer in the future. Again, this was a trial. It just evaluated the early rhythm control strategy, including ablation or antiarrhythmic drugs versus usual care. And interestingly, this is the first trial to demonstrate improvement in the outcome with early rhythm control strategy. And the result of this trial is very important, as we mentioned, that it's the first rhythm control strategy trial to demonstrate improved outcome in patients with early atrial fibrillation managed with rhythm control strategy. But again, this result should be interpreted cautiously because, for example, the AF ablation was used only in 8% of the patients. So it is not a trial comparing ablation procedure versus usual care. And again, there was marked adverse events related to rhythm control therapy. So this is just trial which highlights the importance of having an evidence for reduced outcomes with AF ablation. This is a very important thing to be addressed before the AF ablation procedure, which is regarding the AF management of risk factors for atrial fibrillation. So we know, all of us, that the substrate for atrial fibrillation differs from one patient to another depending on the risk factors and comorbidities and the cardiovascular risk factors. So if the risk factors are not well controlled, the outcome of the ablation or rhythm control strategy will be very poor. So if you have a patient with a hypertension, obesity, and excessive alcohol consumption, obstructive sleep apnea, if these risk factors are not well controlled, definitely the patient won't maintain normal sinus rhythm regardless of the rhythm control strategy. So this rhythm control strategy is very important to be controlled and addressed before the ablation procedure. And I usually tell all my patients before any ablation procedure, if the patient is overweight, he needs to lose weight. If the patient is drinking excessively, he needs to moderate the consumption. If the patient is having obstructive sleep apnea, you should refer to the sleep apnea clinic for possibility of CPAP. So it's very important to control these risk factors before the ablation procedure. And the guidelines mentioned it very clearly. Weight loss, for example, is class 1. So it is class 1 recommendation for obese patients to lose weight before ablation. And risk factors all should be controlled before, again, rhythm control strategy. This is just a highlight of the general recommendation for the ablation. And as we mentioned before, you need to be very clear and to get the patient in the center of the management plan. He needs to know about everything. You should mention the procedure risk and risk factors for AF recurrence following the ablation. And if the patient has had a procedure, this is a very important point, after AF ablation procedure, you should reassess your patient's symptoms. If the symptoms improved markedly, that means that we will be very keen on keeping the patient in normal sinus rhythm all the time. So repeated BVI procedures might be needed. And what we know from the evidence and from the trials is that, interestingly, the success rate of the ablation procedure increases with increasing the number of the ablation procedure. So if the patient has had one ablation procedure and it was not successful, if you did another procedure, the success rate will be higher. This is a new recommendation based on CAPTAF trial. So patients AF catheter ablation should be considered for rhythm control after failed or intolerance to beta blockers. So this is class 2A. So beta blockers alone, if the patient has been given beta blockers and his symptoms was not well controlled, it's class 2A to offer ablation. And again, this is the AF ablation should be offered after failed or intolerance to class 1 or 3 antiarrhythmic drugs. And this has been upgraded for persistent atrial fibrillation. It was class 2A previously, it's now class 1. So any patient, regardless of the clinical pattern, if he has been on medical treatment and it didn't do the job, AF ablation should be offered. What about the first line treatment? So AF ablation now, for the first time, to be considered as first line rhythm therapy in paroxysmal atrial fibrillation, and this is class 2A. So class 2A to offer AF ablation without any trial of medical treatment to go for AF ablation for paroxysmal atrial fibrillation. This is class 2A and class 2B for persistent AF without major risk factors. And sorry, I forgot to mention the risk factors, which is important to know about it, especially for persistent atrial fibrillation. And this includes if you have a massively dilated left atrium, you have long AF duration, other cardiovascular risk factors, or advanced age. So the outcomes is completely different in persistent atrial fibrillation without these risk factors. And if the patient is having this major risk factor, the success rate of ablation will be very low. Again, based on CASTLE-AF trial, AF ablation is now class 1 when tachycardia-induced cardiomyopathy is high probable, and it's usually very easily to suspect. So if you have a patient with normal echo and then you find that you repeated the echo in atrial fibrillation, the ejection fraction is severely impaired and the LV is non-dilated, you should always consider ablating, doing AF ablation for these patients. And again, for selected patients with heart failure reduced ejection fraction, it's class 2A. So if you have a patient still symptomatic despite medical treatment with atrial fibrillation, it's class 2A for patients with heart failure and reduced ejection fraction. I'm not going to go in details regarding the techniques. It is almost the same. So all of us know that the most common trigger for atrial fibrillation is pulmonary vein, and it's class 1 indication to go for pulmonary vein isolation. This is a very nice flow chart for the indication for atrial fibrillation, and these are the 5 new recommendations in the guidelines. So it's class 2A for the first line treatment to offer ablation. So if you have a patient with paroxysmal atrial fibrillation, we have now very clear evidence to offer ablation from the beginning. It's class 2B in persistent atrial fibrillation. However, if the therapy is failed, it's class 1. And patient with tachycardia-induced cardiomyopathy, it's class 1 to offer ablation procedure. There's no much to add about the anticoagulation for patient before and after atrial fibrillation. It is a little bit similar to cardioversion. You need at least 3 weeks before the ablation of uninterrupted anticoagulation, and you might need to use the TUE to exclude left atrial thrombus before ablation. Alternatively, the patient, it's now class 1 to perform the ablation procedure without oral anticoagulation interruption at all. And you need anticoagulation here for post-ablation for at least 2 months, and then according to Shad-Vask score. For cardioversion, you need only 4 weeks. Here it's for 2 months, it's class 1 recommendation. I will just mention here 2 important points. So if you look at the antiarrhythmic drugs, for example, patient being on amiodarone or flecainide or propafenone, in the first 6 weeks to 3 months, it is very reasonable to keep the patient on the antiarrhythmic drug and not to stop it, because first of all, the first 3 months is the blanking period, and usually the patients can get some episodes of atrial fibrillation. So keeping the patient on the antiarrhythmic drugs in the first 3 months, we reduce the AF recurrence and rehospitalization. So the weaning of antiarrhythmic drugs should be delayed till after the first 3 months, and the follow-up is very important for the patient's post-AF ablation, and the first review should be at a minimum of 3 months and then annually thereafter. What about the long-term antiarrhythmic drugs therapy? So before keeping the patient on any antiarrhythmic drug, it is very important to address certain points. So we need to look first of all about the indication. Is the patient having symptoms or not? And secondly, when to start antiarrhythmic drugs. So would you start it after only 1 episode, or you will wait until the patient gets very clear recurrent episodes? How to choose among antiarrhythmic drugs is very important to look at your ECG to exclude having marked AV conduction disorders. It's very important to look at the LV function. You cannot use flecainide, for example, in patient with impaired LV systolic function. You should look at the LVH. Sotalol should be avoided if there is marked LVH. And you should evaluate the ECG, and the patient will need, for example, if the patient is being on flecainide, you need to repeat the ECG 1 week after starting the flecainide because of the risks of proarrhythmia. And sometimes you might end up with a pacemaker if the patient needs antiarrhythmic drugs and he's having a significant AV conduction abnormalities. This is a very nice flow chart regarding antiarrhythmic drugs again, and there is no marked change here. Patient with no structural heart disease, you have flecainide, propafenone, and dornidarone. Class 2B would be sotalol. And if you have coronary artery disease, significant valvular disease, amiodarone, dornidarone, or sotalol, and heart failure with reduced ejection fraction, you don't have except amiodarone. And the main changes in the guidelines regarding the amiodarone now for heart failure reduced ejection fraction is class 1. And it's very potent. However, it should be considered after trial of other antiarrhythmic drugs because of the extra cardiac toxicity. If you're going to keep the patient on flecainide, you need to keep the patient also on one of the AV nodal blocking drugs. And this is a change in the guidelines. We know of course that flecainide in patients with atrial flutter should not be used alone because of the risk of one-to-one conduction. However, in atrial fibrillation now, even for atrial fibrillation, because of the risk of proarrhythmia and also the risk of having atrial flutter associated with AF, you should always keep the patient on AV nodal blocking drug, and this is a new recommendation. It's class 2A. And for sotalol, and although it has been associated previously with increased mortality in management or rhythm control as rhythm control therapy for atrial fibrillation, you need cautiously to keep monitoring QT, serum potassium level, serum creatinine. So if you start patient on sotalol, you need to do an ECG on day 1. You need to have, an ECG baseline, and then day 1 after starting sotalol, and then after 1 week. Very importantly, because sotalol can be a very, very dangerous drug and can end up with sudden cardiac death. The last point to discuss is regarding the comorbidities. And
but please, may I interrupt you for just 1 minute before you move to C, comorbidities? I have a couple of questions also from Hagar Mustafa. She's asking you about the patient that got a single attack of atrial fibrillation due to reversible cause, such as electrolyte disturbance or thyroid dysfunction or excessive coffee intake in a single or maybe repeated episode, but not considered as paroxysmal atrial fibrillation, and he was reverted to the sinus rhythm. Should you continue on anticoagulation in this particular subset with reversible causes that are reverted to sinus rhythm, or they are treated as patients without an intrinsic cardiac disease or structural cardiac disease regarding the anticoagulation?
Okay, so this is very, very nice question. And it's very similar to a question which I'm always being asked. It's regarding post-operative atrial fibrillation. Patient has had a cabbage, and then he has had an episode of atrial fibrillation for 1 minute after the procedure, and then everything was fine. Or patient, for example, with chest infection, developed atrial fibrillation for 1 minute, and then back to normal sinus. And again, there is no evidence that these patients are protected from stroke. So these patients should be anticoagulated according to Shadvask score. We know that the risk of stroke for these patients with very low AF burden is less than patients with persistent atrial fibrillation or with more recurrent episodes, but these patients are not protected. So these patients should be anticoagulated according to Shadvask score. So patients having chest infection, having one episode related to anxiety or stress, having one episode related to, for example, electrolyte disturbance, there is no guarantee that these patients are protected. They should be anticoagulated according to Shadvask score.
So, okay, this is very clear now. The second question, okay, let's have a patient with atrial fibrillation, let's say paroxysmal atrial fibrillation, and you put him with a rhythm control strategy, or you ablated his pulmonary veins, and then this patient now is on sinus rhythm. Will you continue anticoagulation, yes or no? And if yes, for how long?
So as we mentioned before, patient post-AF ablation procedure needs to be anticoagulated for at least 2 months, and then according to Shadvask score. So if the patient is having Shadvask score, for example, 2 or more, or a high Shadvask score, he will need to be anticoagulated lifelong. And again, this is simply because we don't have any evidence saying that AF ablation per se decreases the risk of stroke. We don't, for example, in the future, if we have evidence like that, at that time we can stop the anticoagulation, but we don't have an evidence for that. So patients with atrial fibrillation who undergo AF ablation procedure, this is for symptom relief. It's not for treating or decreasing the risk of stroke.
Thank you so much, Ahmed. Thank you so much for clarifying those two important points.
Thank you. So I'll just go through the last, and sorry for being late. I'll just go quickly through the last point, which is regarding the comorbidities. And this is a very, very important topic, and it has been addressed. And I think, unfortunately, most of us forget about that. So that we always think about medication and ablation, we forgot about the cardiovascular comorbidities. So always keep this rule in your mind. AF never comes alone. So it's very rare to have atrial fibrillation alone. And most of the patients whom we think that they are just having atrial fibrillation, we found a lot of other problems. So we should always look through the comorbidities and the cardiovascular risk factors, and we should always address the lifestyle changes. So having, for example, I'll just go quickly, first of all, through this nice flow chart or nice picture. So patients with diabetes, hypertension, obesity, obstructive sleep apnea, hyperlipidemia, excessive alcohol consumption, smoking, all these risk factors, if we controlled all of these risk factors, this might treat atrial fibrillation, and this will also improve the success rate of any other lines of treatment. So the ablation procedure and the, keeping the patient on antiarrhythmic drugs, all of these strategies, we will have a higher success rate after controlling these risk factors. If you did multiple ablation procedures while the patient is still obese and with uncontrolled blood pressure, definitely the patient will go back into atrial fibrillation. So we have a very clear evidence that controlling the risk factors decrease the burden of atrial fibrillation and improve the symptoms. And it's very addressed clearly in the guidelines. Risk factors should be managed. It's class 1. Unhealthy lifestyle should be modified. Screening for atrial fibrillation, hypertensive and obstructive sleep apnea is very important. And weight loss, as we mentioned before, is recommended as a class 1 in patients before ablation procedure, and in general it's class 2A. And physical activity, this is very important questions, whether AF patients should be, have physical activity or not. Yes, it's recommended and it's considered. However, we should avoid excessive endurance exercise. Endurance exercise will increase the risk of atrial fibrillation, but the normal exercise, moderate level of physical activity is highly recommended. Before I finish, I just want to highlight the most important, and the take-home message from this presentation is just CEC to ABC. If you go through this pathway, definitely you will manage your patient in a very good way. The patient, nothing will be missed, and getting the patient in the center of your management approach is very important. He should be involved in the decision making. Thank you.
That's absolutely amazing, Ahmed. Actually, I enjoyed it so much. Although I'm not a fan of electrophysiology, but I enjoyed it so much. This is a very elegant wrap up for actually not the only the 2020 guidelines, but it's a wrap up for the AF guidelines regarding the approach and the important points. And I think you have a very interesting case in the next 10 minutes you want to share with us. After that, Sharif can rock the stage, inshallah. So, Ahmed, please share your case.
Okay, I'll just go quickly through this case. Hopefully, it won't take long. So this is a very simple case, but there are a lot of learning points. So this is a 62 years old female patient with no relevant past medical history apart from bronchial asthma. Patient is complaining of occasional episodes of palpitation associated with dizziness. And this is the 12-lead ECG. And it's very clear, it shows atrial fibrillation with rapid ventricular response. And the patient has presented to A&E with this ECG, and then after a few minutes, the patient was back to normal sinus rhythm. So my first question, what would you do next regarding the management of this patient? Would you refer the patient to ablation procedure immediately? Would you do an echo and blood test? Would you keep the patient on flecainide? Would you keep on amiodarone, or nothing, or something else?
So we will give 1 minute for our YouTube partners. We have 120 attendees with us, Ahmed. So this is actually a very good number from different nationalities from all over the world. Ahmed is asking you this question: what would you do next? Can you please give us the question, Ahmed?
So what would you do next regarding the management of this patient? Would you do an echo and blood tests, or would you refer the patient to ablation procedure immediately, or would you keep the patient on flecainide, or keep the patient on amiodarone, or something else?
I will take a look now at the YouTube. I will give you by the states from the YouTube. So we have lots of number 1 coming up, echo and blood tests. So actually all of them are voting for echo and blood tests.
Amazing, and this is the correct answer. And I just want to highlight that, as we mentioned before, the CC to ABC approach, we have a clear ECG, so we have confirmed the diagnosis, but we have not characterized atrial fibrillation. So we should not rush into management of atrial fibrillation. We should not rush into medical treatment or ablation or anything before characterization of atrial fibrillation. So we need to go to the 4S AF scheme. You should look at the symptoms, stroke risk, bleeding risk, and as we mentioned, the diagnostic workup. Any AF patient should have proper risk assessment, 12 lead, and the blood test, because if the thyroid function is, for example, thyroid function disorder, electrolyte disturbance, if all of these risk factors are not well controlled, the AF won't be controlled, and transthoracic echocardiography is definitely recommended to exclude marked structure abnormality in the heart. So after the structured characterization of atrial fibrillation for this patient, the patient is having paroxysmal atrial fibrillation. Her symptoms scale 2A, shared VASC score only 1 for female, echo normal with left atrial area of 16 centimeters square, and all the blood tests are normal. So based on this data, and sorry for the data, what would be your first line of treatment? AF ablation, pill in the pocket, wait and see, AF ablation versus pill in the pocket based on patient's choice.
So again, 1 minute for our audience. So Dr. Ahmed gave us data about this patient now, and we got the echo and the lab data, and we need to plan the management and what's the first line of treatment, AF ablation, pill in the pocket approach, wait and see as it is, or AF ablation versus pill in the pocket approach, both available according to the patient's preference. So we're getting the answers for number three. Wait and see. I want a little bit more interaction because I know this is applying what we learned from Ahmed. So we have some answers about number three, and we have some answers about number four. I think it's split vote, Dr. Ahmed,
Okay,
between
so
number three and number four. Maybe you can explain to us.
yeah, I think this is a little bit, I would say, tricky question, but we have these patients having occasional episodes with palpitation, but the patient is severely symptomatic during this episode. The patient gets marked dizziness. And I think that wait and see won't be the best approach for these patients as the patient is severely symptomatic. Usually wait and see if the patient has had only one episode with no marked symptoms. It's good to wait and see if there's only one episode, but in patients with recurrent episodes or occasional episodes of palpitations, it would be very important to intervene early to avoid any further episodes. Whether to go with AF ablation versus pill in the pocket, I would just want to highlight here, we would like to go with rhythm control strategy. The patient is symptomatic and the patient has had only one episode, so she's having a normal erythrometrium also, so she's having factors favoring rhythm control. So we can go with antiarrhythmic drugs or PVI. And it's class 2A to over ablation from the beginning, and we have a clear evidence from CAPTAF and other studies like CAPANA. And in pill in the pocket also is very reasonable. It's class 2A, and especially the patient is already in the hospital. So if you have a patient in the hospital, you can try the flecainide as pill in the pocket to assess the efficacy and safety. This patient was reverted spontaneously, but I mean in other patients, it's important to try first the flecainide as pill in the pocket in the hospital. And the pill in the pocket, usually it's 200 to 300 milligram. Usually the usual dose we give, we ask the patient to take 50 milligram at the beginning of the episode, and then after half an hour to 1 hour, another 50 milligram. And after a few hours, if the attack is persistent, the patient can take another 100. So that's how we give the flecainide. And the same from propafenone. And interestingly, the success rate is relatively high. It's up to 78%. However, as we mentioned, this should be, the safety and efficacy should be assessed in the hospital setting in the first time. You should avoid in ischemic heart disease. You should avoid in patients with atrial flutter with one-to-one conduction. And you should monitor the ECG. If the patient has had a flecainide, a pill in the pocket, we will monitor the ECG for the first time. And if it's safe, the patient can have it later on outside the hospital setting. So we have two options, the ablation and the pill in the pocket, and the decision should be shared with the patient. And this is very important after addressing the benefits and risks from both approach. The patient has been kept on flecainide as pill in the pocket, and she was doing well, symptoms markedly decreased, and she felt much better. And the GP was doing an ECG routinely, and this was the ECG. It's not of the best quality, but hopefully it is clear. So this is the ECG, and then Based on this ECG, what would be your advice? Prescribe AV nodal blocking drug, use amiodarone instead of flecainide, stop flecainide, permanent pacemaker.
So this is a real life scenario, by the way, because Dr. Ahmed told me that he has been following up this patient. So this is a real life scenario. We had a patient with atrial fibrillation. We decided to do the proper investigations, which were done. After that, we prescribed her pharmacotherapy, and then she was on the oral medication, flecainide, and then the patient developed what we see now, which is a left bundle branch block on her ECG, and she is on sinus rhythm, actually, but the ECG complexes give us the criteria for left bundle branch morphology. And here Dr. Ahmed is asking us upon this ECG, what would be the next step? Maybe you can give her an AV nodal blocking drug, maybe you can change flecainide to amiodarone, or you can stop flecainide since she's sinus now and you can continue without any medication, or maybe she needs a permanent pacemaker. So I will take your votes and I will transfer those votes to Dr. Ahmed. So please vote. So I'm getting most of the votes moving towards number two or choosing number two, using amiodarone instead of flecainide. So we will stop flecainide, but we will give the patient amiodarone according to those votes.
Uh, so this is not, yeah, okay. So the answer of this question is a little bit difficult. I know that it's not very very clear, but I think that it's not only about guidelines, but about the management of the atrial fibrillation. So these patients with paroxysmal atrial fibrillation, and she gets occasional episodes. She doesn't have any previous cardiac history. Definitely, we would stop flecainide. So I agree with stopping the flecainide, but as we mentioned before in the guidelines, the amiodarone is mainly restricted as a last resort because of the extracardiac toxicity. So I would say that in this patient with paroxysmal atrial fibrillation, I stop flecainide. I won't give amiodarone, especially that patient having left bundle branch block. Keeping the patient amiodarone, there's still a risk of having significant bradyarrhythmias. So I would stop flecainide, but I won't give amiodarone for this patient. Uh, this is very important regarding the pharmacological cardioversion to know if the patient is having AV conduction disorders like left bundle or prolonged QTC or sick sinus syndrome, we should avoid pharmacological cardioversion and it should not be attempted unless the risks are being considered. So it's very important always that when you keep the patient on antiarrhythmic drug, you should always, especially in for long term, you should always keep following up the patient and do repeated ECG because the patient very easily can develop significant AV conduction disorders. So my next step regarding the long-term management plan for this patient, would you switch the flecainide to profenone, switch flecainide to sotalol, pace and ablate strategy, AF ablation of symptomatic? What would be your long-term management plan for this patient?
So now we agreed on stopping the flecainide, and we agreed upon not replacing the flecainide by amiodarone. So the options Dr. Ahmed are offering us now are using propafenone, using sotalol instead of the flecainide, or pacing the patient and ablating her AV node and inserting the dual chamber pacemaker, or AF ablation by pulmonary vein isolation or whatever. So the votes are for you now. Please on YouTube vote. getting 100% votes, Dr. Ahmed, to do AF ablation.
Amazing. So I think that AF ablation would be very reasonable. And what I want to highlight, so we know that it is class 1 if you are having failed or intolerance to antiarrhythmic drugs, and it's class 2A if it is as a first line treatment. So what I want to highlight here before finishing is that ablation procedure, you should always think about the ablation procedure if you have any concerns about antiarrhythmic drugs. So ablation procedure will do the job, especially in paroxysmal atrial fibrillation. And I would say that early referral for AF ablation procedure will increase the success outcome. So in patients with intolerance to antiarrhythmic drugs or side effects from antiarrhythmic drugs or at risk of proarrhythmias, early refer to ablation will be very reasonable. And as I mentioned, it's class 1 in case of failed or intolerance to antiarrhythmic drug, and it's class 2A as first line therapy. Thank you, and sorry for being a little bit out of time.
Thank you so much, Ahmed. Actually, I'm enjoying this. I didn't feel the time at all. We planned a 45-minute session, but actually it's very interesting. I would like to thank you so much, and all our viewers are extending their deepest thanks to you, and lots of likes and shares actually are going on. So I think we have Dr. Sharif Touhi. Sharif is my friend and is Ahmed's friend as well. Sharif is a PhD from Ain Shams University, and he's an MRCP also, and he received some training in the United Kingdom and is currently one of the most eminent consultants of electrophysiology in Egypt. Sharif is an excellent teacher. I enjoy learning from him, and he has a talent about simplifying the data and giving us different case-based scenarios. So Sharif will discuss with us case-based scenarios according to the ABC pathway, and also Ahmed will be moderating this session with myself. So Ahmed, feel free to interact with Sharif whenever you feel it's needed, and I will convey the YouTube questions on the chat. So please, Sharif, you have the mic now. Sharif, can you hear my voice?
Hello, Dr. Zahran. Yeah, I'm
Okay,
here.
please go on.
Yeah, okay, so you can see the presentation.
Yes, it's very clear.
So thank you very much for this initial presentation that you present for me, Dr. Zahran. It's my pleasure to be here today. So what I'm going to do is that I'm going to present 4 cases in order to apply the AF in special situations. Of course, Dr. Ahmed Ammar has made my job very easy because he simplified all the new issues regarding the AF guidelines. So now I'm going to start to apply 4 of the common clinical situations that were very important and were updated in the guidelines this year. Of course, we should not forget this algorithm, which Dr. Ammar has explained regarding the CEC to ABC, confirming AF, characterize the 4SF scheme, and then the APC pathway. So of course, we are going to apply this in each situation, but of course, each situation which has its different issues or logistics. So let's first start with case 1, which is like warming up with a short case. You are seeing a 63-year-old male patient who presented to the ER with right-sided weakness of 4 hours duration, and his CT brain proved that it was caused by acute cerebrovascular stroke. It was ischemic stroke with no evidence of hemorrhage. He received TPA infusion, resulting in successful reperfusion. He is known hypertensive for 5 years, and he is heavy smoker and diagnosed as COPD 4 years ago. His ECG showed normal sinus rhythm and echoes are remarkable, and the neurologist is now seeking your opinion as he suspects that the stroke is embolic in etiology, and he suspects paroxysmal AF to be the cause of thromboembolism, although the patient has no previous documentation of AF. So my question now for all of you, what are you going to do regarding this consultation? Number 1, no need for suspicion of AF as a cause, as he has no history of documented AF. Number 2, start on empirically on oral anticoagulation. Number 3, arrange for ECG monitoring. So what are you going to think of? So can we vote for this?
So this is a real life scenario actually. Yes, we are voting actually on the YouTube now. Please vote. This is a real life scenario. We get this consultation several times every week from different hospitals and from different colleagues. Sometimes you get it in the form of a stroke. Sometimes you get it from the ophthalmologist having a patient with a central retinal artery occlusion and acute vision loss, which is not explained. And he says maybe this is an atrial fibrillation. You get a patient with an acute limb ischemia of unexplained cause. All of them are the same scenarios, and actually you have the question, you have the ECG is normal, you have the echo is normal for an instance when the patient was lying on the bed. So can this moment where you recorded the ECG or the echo and the patient was lying on the bed and it recorded a normal sinus rhythm, does this mean that this patient did not have atrial fibrillation? This is the core of the question that Dr. Sharif is asking you. So please vote on the YouTube and I will convey your votes to Dr. Sharif. So all of the viewers, actually, Dr. Sharif, now are voting for number 3, arrange for ECG monitoring, because they believe that the momentary recorded ECG and echo cannot be monitoring the 24/7. So please explain the answer.
Okay, of course, I agree totally to this answer that it is arranged for ECG monitoring. Although previously, what we were saying to the neurologist in this case, that this patient, for example, is more than 6 years old, so of course it is a ischemic stroke and no need to think of embolic stroke. And so, of course, this is now not the guidelines or this is not the updates now, which are going for arranging for ECG monitoring. Of course, in cryptogenic stroke, which of course is a famous terminology used by neurologists, so far there is no evidence for routine oral anticoagulation use in these patients. If you don't have a certain etiology, so there is nothing called empirical or anticoagulation, even if the patient has recurrent strokes without documented AF. But what the guidelines stated this year is that some or certain subgroups of patients, like the elderly, CKD, patients with enlarged left atrium, can benefit from oral anticoagulation because they may have paroxysmal AF that doesn't have documentation. And there is a new score which was issued in the guidelines called the CHEST score, in which including coronary artery disease or COPD, 1 point for each one of them, hypertension, elderly above 75 years, it takes 2 points, systolic heart failure, 2 points, for thyroid disease or mainly hyperthyroidism, 1 point. And so, using this score in order to identify who is the patient who is at high risk of developing atrial fibrillation. And according to this, I can mention that this patient is risky to have paroxysmal AF, but I didn't catch them yet. That's why in the guidelines, it is class 1 that patient with acute ischemic stroke or TIA, and the patient has no documentation. Monitoring is indicated for the first 24 hours for short-term ECG recording and then continuous Holter monitoring for about 72 hours whenever possible. And I think many of you has heard about this practice in many hospitals that the neurologist asks routinely for Holter monitoring for all patients with AF, not just echocardiography. And also in selected patients who are assumed that they are high risk, long-term non-invasive ECG monitoring or even implanting loop recorders maybe it should be considered in order to detect AF if I suspect that the patient is risky to develop AF. And so far, the use of routine ECG monitoring is very important. And if I documented that this patient has evidence of paroxysmal AF using ECG monitoring, should assume that, of course, NUAC are much more better than VKA because they are associated with low risk of intracranial hemorrhage, and compliance is very important, and no role anymore for addition of aspirin or supratherapeutic INRs in patients with recurrent stroke. So the practice now for patients with cryptogenic stroke is to arrange for ECG monitoring and not just assume that the patient has no documented AF. So, okay, Dr. Zahran, we can move now to the case 2. Does anyone have any
Yes,
questions
I
regarding?
would like to ask, yes, I would like to ask a question. For how long, Dr. Sharif, would you do the ECG monitoring? Is a 48-hour holter enough? Would you make an extended recording for 1 week? Would you implant something? This is a very brainstorming question. I don't know, jump to my brain now.
Okay. I think that the guidelines didn't clearly answer and the question regarding the duration of the long-term ECG monitoring. The problem is that in Egypt, we don't have available device for long-term ECG monitoring like cardiac memo or Nubovest or loop recorders, which are available abroad, of course, and we have seen them abroad, but in Egypt, they are not available. But I think it depends on the suspicion of the patient. If the patient is suspected to be at the high risk of having atrial fibrillation, and also if the neurologist is much suspecting that the stroke is embolic, and I think the neurologist have some features that suggest that the stroke is embolic at that time, long-term ECG monitoring abroad may be much better, like cardiac memo for about 2 or 3 weeks. But in Egypt, I think they only use the Holter monitoring for about 72 hours or even 4 days because this is the most available. But a certain duration was not answered in the guidelines.
I agree with Sharif, Zahran. I just want to add something that because of what Sharif has mentioned regarding the importance of monitoring for patients after stroke, after cryptogenic stroke, the NICE guidelines recently has been changed, and now it is recommended to implant loop recorder for patients with cryptogenic stroke to exclude atrial fibrillation. So they are recommending long-term monitoring. And as Sharif mentioned, it is very challenging that unfortunately in Egypt, we don't have the implantable loop recorder available, so we could not monitor the patient for a long time. So I think that what we can do based on the, unfortunately, the absence of the implantable loop recorder is try to stratify your patient. So if you have an elderly patient or patient with recurrent stroke or patients with multiple risk factors for stroke, I think that at that time, the patient will need a very long-term monitoring, and at least we might need to repeat the 24 or the 48 hour or the 72 hour table. What is it? I mean, what is the longer available? We should just try to monitor as long as possible. But definitely, if there is a loop recorder, it is highly recommended to implant that, especially in patients with high risk factors for stroke.
Okay, of course. Thank you very much for this, Dr.
Thanks a
Amari.
lot, Ahmed and Sharif, for this notification. Yes. So please proceed, Sharif.
Okay, so case number 2, I think this is the most interesting case today. Although I didn't put a direct question it because the management is slightly complex here, but I think everyone will enjoy this case. We're having here a 57-year-old male patient who presented to the ER by typical chest pain of 2 days duration on and off, and he is known hypertensive and diabetic, but no previous cardiac history. His ECG showed AF with rapid ventricular rate, and it showed also 2 mm ST depression in V4, 5, and 6. His troponin was positive, but his creatinine was 1.8, and when we calculated the creatinine clearance with the Cockcroft Gold formula, it was 45 milliliter per minute. And echocardiography was performed, and it showed mildly impaired or moderately impaired LV systolic function with severely hypokinetic inferior and lateral wall. Of course, when the consultant was informed, his decision was to arrange for early invasive strategy based that this patient has non-STEMI, and although also he has atrial fibrillation and the creatinine is high, but of course this didn't change the decision, and we are going directly for coronary angio, and it showed that he has proximal RCA thrombus containing total occlusion, and he had PCI by 2 overlapping drug-eluting stents from the proximal to mid-segment restoring TMS3 flow, and of course, radial access was used. Now the patient is chest pain free and his ECG is still showing AF. So what will be your management here? Of course, it was very difficult for me to put an MCQ question here because of course the management here is very complex because what we are speaking about the anticoagulation, the antiplatelet therapy, whether we are going for rhythm control or rate control. So that's why I omitted the question here in this case per se, and I'm going to discuss in simple way how we are going to manage this very common clinical situation. Of course, I am using the same integrated APC pathway as we are going to start with the anticoagulation, then better symptom control, rate versus rhythm, then the cardiovascular and comorbidity optimization, and it will have a great role here because we are speaking about a patient who is hypertensive, diabetic, and ischemic. So let's start with the Charles-Vasque score. The score for this patient is 4 based on hypertension, diabetes, coronary artery disease, he is having myocardial infarction, and he has moderate LV dysfunction, And we know from the guidelines that even if the LV dysfunction is asymptomatic, it should be put in that score. But please don't forget to calculate the Hasplit score here, which is 2 based on the uncontrolled hypertension and abnormal kidney function. And we know from the guidelines here or this year, and also from the previous guidelines, that Hasplit score should not be used to stop or prevent oral anticoagulation, but its benefit is to modify the modifiable or control the modifiable risk factors for bleeding if the patient has high risk of bleeding, and we need to start on oral anticoagulation. Of course, we know that there are 4 rate control trials that compared dual therapy with P2Y12 inhibitor, and many of you has heard about them, as they compared the dual therapy using clopidogrel with oral anticoagulation with the triple antithrombotic therapy, like the REDUAL trial, Pioneer trial, Augustus trial, and the Entrust AF trial. But all of these trials had a primary safety endpoint for bleeding, and so they were underpowered to assess ischemic outcomes. One of the very important trials in them is the Augustus trial, because it has a characteristic feature that it was 2x2 factorial design. And so it compared two regimens, and each one of them has 2 subtypes. So this trial showed that placebo versus aspirin and apixaban versus VKA regimen were associated with significant reduction in bleeding, and apixaban, of course, was associated with significantly lower rates of stroke, death, and hospitalization. And so all these trials were going toward shortening the duration of triple therapy to decrease bleeding risks. Of course, in this patient, we should assess what are the thrombotic risk factors for this patient. What I mean is that what are the risk factors that increase the risk of thrombosis, like diabetes, which is present in this patient, prior acute coronary syndrome, multivessel, premature coronary artery disease, the clinical presentation that is coming by acute coronary syndrome, the CKD, whether it was complex revascularization or not. I should also assess the bleeding risk factor, which are parts of the Hasplit score, and I should assess the maneuvers in order to reduce bleeding risk associated with PCI. So these factors should be put in consideration. So let's translate them into practice here. Of course, I'm going to use NOAC in preference to VKA as regarding the anticoagulation. And if the patient Hasplit score is high at the time, I would use a reduced dose of rivaroxaban or dabigatran. And if I'm going to use VKA, target INR should be from 2 to 2.5, not 2 to 3. And of course, here, this patient or the guidelines dictate or differentiate between chronic coronary syndrome and acute coronary syndrome. So if the patient is having chronic coronary syndrome, as the patient, for example, is presenting with elective PCI, at that time, the triple therapy should be for less than 1 week or maximum 1 week. And after this week, I should stop the aspirin and continue with the dual therapy up to 6 months. And in this dual therapy, prefer to use clopidogrel with the oral anticoagulation, and the oral anticoagulation of choice is VKA. And if the patient has high risk of stent thrombosis that outweighs the bleeding risk, the patient, for example, had complex revascularization, the maximum duration for triple therapy is 1 month, and then continues for only 6 months. And these is examples of high ischemic risk like complex revascularization, stent length, diabetes, or bifurcation. But in this situation, the patient is having acute coronary syndrome. So I would apply the same rule here, but the only difference that the patient here would have the dual therapy continued for 12 months. So here I would stop the aspirin early within less than 1 week, and then discharge the patient on dual therapy with clopidogrel and oral anticoagulation for up to 12 months. And after this 12 months, I would stop the clopidogrel and continue with oral anticoagulation. And if I'm concerned with high ischemic risk, because here, for example, the patient is having acute coronary syndrome, and I have put 2 stents in a thrombus-containing lesion, and of course, the stent length here may exceed 60 millimeter because I have put from proximal to mid-RCA, I can extend the duration of the triple to about 1 month. And this is mostly what we are going to do here in this example, because the patient is diabetic, he has CKD, he has stent length mostly of more than 60 millimeter. So what I'm going to do regarding triple therapy, I would give aspirin, clopidogrel, oral anticoagulation for about 1 month. Then I would continue the clopidogrel and the oral anticoagulation for 1 year, then lifelong oral anticoagulation because his Chas-Vasquez score is 4. Of course, I would prefer here to use NUAC rather than VKA. And if I am obliged to use VKA, the target INR should be 2 to 2.5. And I would give proton pump inhibitor, of course, to guard against GIT bleeding. And what is the dose of NUAC in this case? I would use here, of course, the full dose, except if there is any recommendation to use a reduced dose. So here, of course, this table is from the most recent guidelines in AF, which dictate when to reduce the dose. So creatinine clearance less than 50 is not always a recommendation to reduce the dose. For example, in dabigatran, creatinine clearance here, it was not dictated here, but for example, in apixaban, because it was the least dependent on renal elimination. Here, serum creatinine above 1.5 is not only used to reduce the dose, but the body weight and age also should be used. So this table simplified to us when to reduce or use to reduce dose of NUAC. And here, of course, we know that the Haskell score was low. And this image or this diagram, of course, it was from the EHRO guidelines of NUAC, dictating that below 30, it is contraindicated to use the dabigatran, but below 15, all of the other NUACs are contraindicated. Between 15 and 30, I can use apixaban, edoxapan, or rivaroxaban. So here, NUACs, of course, we should remember in these guidelines that NUACs are not approved to be used in Europe, for example, in creatinine clearance less than 15 millimeter per minute or patient on regular dialysis. So in this case, if the patient has creatinine clearance less than 15, I would use VKA, not NUAC. Okay. And this table, of course, in case of chronic liver disease in child C, all NUACs are contraindicated, but in child B, only rivaroxaban is contraindicated. So let's summarize the rule. Triple therapy here is indicated for at least 1 week and maximum 1 month. Dual therapy with oral anticoagulation, antiplatelet, preferably clopidogrel, is recommended for the first 12 months after PCI acute coronary syndrome or 6 months after PCI in chronic coronary syndrome. Avoid prasugrel or ticagrelor here to reduce bleeding risk. And concomitant use of proton pump inhibitor is encouraged. And of course, patient treated with CABG at this case, use only the dual therapy and avoid triple therapy. So now regarding the, I'm going to bypass these points because in order for time, this is a diagram in these guidelines illustrating the role of triple therapy. So this is a change from the last guidelines in atrial fibrillation and the guidelines of depth and myocardial revascularization. So now I have answered the question regarding how to use antithrombotic therapy. What about the dilemma of rate control versus rhythm control in this patient? What I'm going to do here? Of course, rate control, as Dr. Ammar has explained, what is the role of rate control, and the lenient control is the first choice, except I need to have strict control because, for example, I suspect AF-induced cardiomyopathy or the patient is still symptomatic in lenient control. And based on the patient here, ejection fraction is moderately impaired, I can apply the rule for heart failure with reduced ejection fraction that the first line treatment is beta blocker. And then if the beta blocker are insufficient, I can add digoxin, but I cannot use here verapamil or diltiazem. And the last line is the ablation and pacemaker, but we are not going to do this here. So the first choice for rate control is beta blockers and digoxin in this example, and I cannot use calcium channel blockers. But what about rhythm control? Rhythm control, as the guidelines said, it is recommended only for symptom and quality of life improvement in symptomatic patients with AF. So, of course, rhythm control is not a must in most of the patients. But as Dr. Marin has explained, that the guidelines are also favoring the use of rhythm control and cardioversion, because in some cases, even if the patient is asymptomatic, he may have subconscious adaptation to reduce physical activity. And if the symptoms are present, I should assess whether they are related to atrial fibrillation or not. And then the most important factor here is that I should assess factors favoring rhythm control. If the patient is young, it is his first AF episode. If the patient has LV dysfunction, and I assume that it may be due to AF. If the patient has normal or moderately increased left atrial volume, it is not severely dilated. If the patient has few comorbidities, if the patient rate control is difficult to achieve, if it was precipitated by a temporary event at that time, I would go for rhythm control. So if I consider this patient, that this patient is ischemic and having LV dysfunction, and this AF may be long-standing, but also it may be due to the MI. And so I may consider that the AF here was precipitated by temporary event. And if the echo showed that the atrium was not severely enlarged, I would favor going for rhythm control. And of course, here I would go for elective cardioversion by either TEE to exclude thrombus and then going for cardioversion, or going for optimal anticoagulation for at least 3 weeks, because I don't know the duration of the AF here in this patient. And here, of course, in this patient who is having LV dysfunction, I could favor electrical cardioversion after TEE, of course, or 3 weeks anticoagulation, or pharmacological cardioversion using IV amiodarone. I cannot use flecainide or propafenone because of the LV dysfunction, and I cannot use sotalol due to LV dysfunction. Sotalol can be used in ischemic patient, but in LV dysfunction, I cannot use it. I may consider ablation here. Yes, I can consider because the patient has persistent atrial fibrillation and heart failure with reduced ejection fraction. At the time, I may go for catheter ablation class 2A, but this is a decision that could be decided after discharge. And at last, of course, I should not forget the last letter in the APC scheme. This patient is hypertensive, he is diabetic, and maybe he is dyslipidemic, maybe he is overweight. So I should control these risk factors to reduce the risk of recurrence of AF. And this is the last letter in that APC scheme. I know I was slightly rapid in this case, but I know that, of course, many of you have questions, so I can give some time for any questions.
Yes, please, Sharif, I have a question from Hagar Mustafa. Do you need to reduce the dose if you are if you are using NOAC in the triple therapy? I mean, NOAC can be, the question should be like this. First of all, NOAC is used in the triple therapy, or the triple therapy only applies to vitamin K antagonist? This is number one. I think also this is my point of view that the triple therapy would include the dual antiplatelet as clopidogrel because you cannot use the other two. The question is also what if the has bled is more than 3? So can you clarify the triple therapy choice, Sharif, in the anticoagulation slot? You will use the VKA or the NOAC in the dual antiplatelet slot. In the P2Y12 blocker, you will use the clopidogrel or the ticagrelor or prasugrel. And if the has bled is more than 3, I think you will move to the 1 week strategy rather than the 1 month strategy. So what's your answer?
Okay, so of course, I think in this example, the guidelines in this year favored shortening the duration of triple therapy as much as we can. So for example, if the patient has split score is 3 or more at the time, I would favor early stoppage of aspirin and continuing on clopidogrel and the full dose of NOAC, or if the patient cannot afford NOAC at the time, I could use warfarin. So in case of high bleeding risk or split score, I would early stopping the aspirin even before hospital discharge. Regarding the anticoagulation, of course, the anticoagulation of choice is NOAC rather than warfarin. So if the patient can use NOAC and he doesn't have any contraindication for it, at the time I would choose it. So the dosage of the NOAC, as I mentioned in this table that I mentioned here, there is no recommendation to reduce the dose of NOAC in triple therapy. It was mentioned in the guidelines of the DAPT in 2017 to use a reduced dose of some of the NOACs in case of triple therapy. But the only recommendation in these guidelines, and I would get it here now, it was mentioning that in case of split scores that was very high or high more than 3, in this time, we can use a reduced dose of rivaroxaban or reduced dose of the bigatran. In this case, I could use it a reduced dose. And the other recommendations for reduction are shown here in this table. Regarding the P2Y12 inhibitor, P2Y12 inhibitor in this example, of course, clopidogrel is the P2Y12 inhibitor of choice. Yes, here I can show here that rivaroxaban 15 milligram is considered in preference to 20 milligram in case of high split score and the bigatran 110. This is the only recommendation regarding reducing the dose of NOAC. I should not use prasugrel or ticagrelor because only one trial of the 4 trial used ticagrelor in this trial in minority of patients. So clopidogrel is the P2Y12 inhibitor of choice. And of course, if I choose dual therapy, I should stop aspirin and choose clopidogrel, not choosing to stop clopidogrel because I cannot prescribe the patient to be discharged on just NOAC and aspirin. I would prescribe clopidogrel and NOAC or clopidogrel and warfarin. So
Thanks
have
a
I
lot.
answered?
Yes, thanks a lot for clarifying this point because this is a very important point. And as the risk profile of the patient is getting more and more, we're seeing lots and lots of patients where we are particularly faced by this particular situation. So thank you so much, Dr. Sharif, for clarifying this point. I think we can see a
I
big screen now.
I just want to highlight, sorry for that, just want to
Yes,
highlight
yes, please go.
regarding the antiplatelets of choice. So as Sharif mentioned, in triple therapy, you don't have other options apart from clopidogrel. So you cannot use ticagrelor or prasugrel as a part of triple therapy. But in dual therapy, if you're going to give a dual therapy, you can still use ticagrelor or prasugrel, especially if you have a very high ischemic risk. And this, I think, in the new non-ST guideline, this is a class 2B. So clopidogrel is the safest and it's the most well studied. However, if you have a very high ischemic risk, you still have the option to use ticagrelor or prasugrel as part of dual therapy, oral anticoagulant beside the antiplatelet.
That's right. I totally agree, Dr. Ammar. Because some cases, for example, he has history of stent thrombosis on clopidogrel. In this case, I may choose to use ticagrelor with anticoagulants in case that I am afraid of the recurrent stent thrombosis because he had already stent thrombosis. In this case, I can use ticagrelor. This is an exception in this case.
Definitely. Thank you.
Okay. So case 3 would be much shorter and there will be a question it. 34-year-old pregnant female at her 16th week of pregnancy is referred to you by her obstetrician as she complains of palpitation and dyspnea on mild exertion of 1 week duration. ECG showed AF with rapid ventricular rate at 120 beats per minute. She has no past medical history or any previous cardiac history, and her echo and labs were unremarkable. So now I'm faced with pregnant lady with atrial fibrillation. And now what would be the choice? Start her oral anticoagulation and rate control till delivery. Number 2, rate control only without oral anticoagulation as her CHAS-BASC score is 1 based on her gender. Or number 3, arrange for elective cardioversion. So I can give some time for voting, Dr. Zahran. So what do you think here in this example? What we are going to do with a pregnant lady with atrial fibrillation?
Yes, this is a particular situation actually where we get lots of questions for pregnant females. Is it safe to use medications? Which medication shall we use? Should we add oral anticoagulants or not? Is NOAC safe during pregnancy or not? If we're going to use a vitamin K antagonist, is there a specific dose after which you can get some fetal malformations? Is it better to use cardioversion? So this is a real life scenario actually. So our friends on YouTube can start voting, and I will convey the vote to Dr. Shi. So, Sharif, the trend is going towards number 2, rate control without oral anticoagulation because our CHAD-RASC is 1 being a female, and split decision with number 3, arrange for elective cardioversion. So maybe you can explain the rationale.
Okay, I will explain because I think it is a confusing case, and that's why I was thinking that most of the answers would be divided between choice number 2 and number 3. So, of course, AF is considered one of the most frequent arrhythmias during pregnancy, especially in women with congenital heart disease, valvular heart disease, and we are in our country. Rheumatic heart disease is very common, so it is very common to see AF in patients. But also, it is not uncommon to see AF in patients with no structural heart disease, what was previously called lone AF, but of course this terminology was abandoned in these guidelines. And atrial fibrillation is associated with increased risk of mortality due to serious hemodynamic consequences for the mother and fetus. So don't consider AF as a safe arrhythmia during pregnancy, and I would only consider the high-risk arrhythmias are VT and SVT. No, AF is a high-risk arrhythmia in pregnancy, and it should not be left alone without any treatment. And pregnancy, of course, is a problematic condition because it is associated with hypercoagulable state. And so this patient is associated with increased risk for thromboembolism and stroke during pregnancy. Of course, we all know NOACs are still contraindicated during pregnancy, and the guidelines are the same. They are not proved to be safe during pregnancy. And vaginal delivery, of course, should be advised for most women, but it is contraindicated while the mother is taking warfarin because of the risk of fetal intracranial bleeding. Of course, the guidelines was clear that the patient, if having atrial fibrillation and hemodynamically stable, of course, she should have emergency or immediate cardioversion or pre-excited AF. And then they mentioned that pregnant women with hypertrophic cardiomyopathy should have cardioversion as class 2A. But actually, in the full text of the guidelines, they mentioned that rhythm control is much more favored than rate control in pregnancy, even without structural heart disease. So although the guidelines here was clear that patients with hypertrophic cardiomyopathy should have cardioversion, also rhythm control is still the preferred strategy in pregnancy. And I think in the previous guidelines in 2016, it was mentioned clearly that rhythm control should be favored during pregnancy in the box of the guidelines or in the pocket guidelines. Here it was not mentioned very clearly. Of course, the medications here that can be used, and of course it is important to know that eputylide, flecainide can be used in patients with structurally normal heart and they are not contraindicated during pregnancy. Warfarin can be used during pregnancy, but of course we have the issues of the first trimester and stopping it before delivery. Beta blockers, especially the selective beta blockers, can be used for rate control. It is not a problem to use metoprolol or bisoprolol. Flecainide, propafenone, sotalol can be used also to maintain sinus rhythm in patients with atrial fibrillation, and they can be used during pregnancy. Digoxin and verapamil can be used during pregnancy. So please don't be afraid to use these medications during pregnancy. It is proved that they are safe in pregnancy. So rhythm control is still the preferred strategy. And of course, we are not thinking of AF ablation at all during pregnancy because it's not urgent. So let's apply the APC scheme. Anticoagulation, what I'm going to do for this female. I would start her or anticoagulation as atrial fibrillation is detected because now she is in fibrillation, and so there is a risk of thromboembolism, especially that pregnancy is a thrombophilic condition. And of course, warfarin is a drug of choice, and avoid NOACs during pregnancy, and avoid warfarin in the first trimester if more than 5 milligrams is needed, and stop it at least 1 week before the expected date of delivery. Then what I'm going to do, I would choose rhythm control, not rate control. I would arrange, because this patient is more than 48 hours, to go for TEE or strict oral anticoagulation for 3 weeks, and we can do TEE during pregnancy, it is not a big deal, or oral anticoagulation. And if it is free TEE with no left atrial thrombi, or the patient was anticoagulated strictly for 3 weeks, I can go for electrical cardioversion or pharmacological cardioversion, flecainide or propafenone, if she is having structurally normal heart, as in this example, in order to restore sinus rhythm, which would be much better for the hemodynamics of the mother and the fetus. DC shock, of course, as we know, it can be performed safely during pregnancy without compromising the fetal blood flow, just to give sedation with attendance, better to be with attendance of anesthesiologist, and then going for DC shock without any risk for fetal arrhythmia or preterm labor, but just we need the obstetrician to monitor the fetal rate after cardioversion. Then, in order to maintain sinus rhythm during the rest of the pregnancy and reduce the risk of recurrence, we can use oral propafenone or flecainide, or also we can use oral sotalol, unless there is evidence of structural heart disease, because as we know, these medications are contraindicated in LV dysfunction, coronary heart disease, and LVH. Sotalol is only contraindicated in LV dysfunction, LVH, but it can be used in coronary artery disease if the LV function is preserved. And of course, amiodarone is contraindicated during pregnancy. We cannot use amiodarone for a pregnant lady. And of course, till you achieve the rhythm control, you need to have rate control. I can use selective beta blockers like metoprolol or bisoprolol, but avoid atenolol in pregnancy. It is contraindicated. Non-DHP calcium channel blockers, digoxin can be used, but remember, if she has evidence of manifest pre-excitation, at the time you cannot use this medication. Anticoagulation then should be continued for at least 4 weeks post-cardioversion. And after this, as her Chas Vasco score is 1 based on gender only, we can stop it. Because remember from a very basic information that atrial fibrillation is restored, or sinus rhythm is restored electrically before it is restored mechanically. And so the left atrial kick may be not efficiently restored for the first 4 weeks. And so regardless Charles-Basque score, at least 4 weeks, especially that she is having AF more than 24 hours. From these guidelines, patient with AF more than 24 hours and then he underwent cardioversion, anticoagulation should be continued for at least 4 weeks. And if the patient is having atrial fibrillation for less than 24 hours at the time, we are not obliged to proceed for oral anticoagulation for 4 weeks. So in this case, I would choose the choice
So
number three.
just a minute, yes, a minute, Sharif, because I think the last slide answered the question I'm just going to post now. Our dear friend, Dr. Khalid Ethiopi from Ancient University is asking you, is pregnancy alone per se an indication for anticoagulation in atrial fibrillation patients with no risk factors? I think the last slide answered this question. What do you think?
If I
Pregnancy alone.
Oh yeah, of course, yeah. So I think by the Charles-Basque score, which is still the rule used by the guidelines in order to assess risk of thromboembolism, no, pregnancy itself is not a risk factor or not a part to indicate oral anticoagulation in a pregnant lady. And that's why in this patient, I choose that she would have at least 4 weeks post-cardioversion, and then I would stop it because the Charles-Basque score is only 1. But remember that I choose that this patient should be started in oral anticoagulation once I diagnose atrial fibrillation, till I arrange for cardioversion, because as she is in AF, she has a risk of thromboembolism, especially that pregnancy, of course, theoretically, increase the risk of thromboembolism. So the answer to this question is that no, it shouldn't be used as an indication for oral anticoagulation, but put in your mind that rhythm control would be much, much more favored in order to reduce the risk of thromboembolism, especially that she is pregnant and at risk of thrombophilia.
Yeah, I agree with you, Sharif. I think it's very clear. Let's make it very clear. So the pregnancy is associated with hypercoagulability and increased thromboembolic risk, but there is no data to suggest that pregnancy should be considered as indication for anticoagulation if the patient developed AF. And the guidelines is very clear, and the patients with pregnant patients should be managed regarding the anticoagulation similar to the patients, non-pregnant patients, regarding the risk stratification. So we use the Charles-Basque score as in non-pregnant patients. So if the Charles-Basque score, as Chief mentioned, one only for female, theoretically, if you're not going to cardiovert, there is no indication for anticoagulation at all. But as Chief mentioned, the rhythm control strategy would be better for pregnant patients, and that's why he started the patient on anticoagulation.
That's right, I agree, of course, Dr. Amar. So any questions or move to case 4, Dr. Zahran? Dr. Zahran, can we move to case 4 or any other questions?
No questions up till now, so please you can move to case number 4.
The last case. So this is our last case today, case number 4, which would be an interesting case. 49-year-old male patient is scheduled for aortofemoral bypass surgery for his peripheral arterial disease. His procedure passed uneventfully, but in the post-operative ICU, he developed new onset AF. Very common scenario, of course, and very common situation that we have a lot of consultations in our practice. It started 6 hours after the surgery. The patient started to feel dyspnea and palpitation when the AF started, and he is known to be a heavy smoker, but he has no any other risk factors and no past cardiac history. So we are faced with a situation of post-operative AF. What are you going to do? Start him in oral anticoagulation and rate control, wait for delayed cardioversion, arrange for elective cardioversion. So what will be your choice here?
So let's give them a chance to vote for 1 minute. So this is a common patient post-operative atrial fibrillation. What's the next step? Start on oral anticoagulation and rate control, so he's gonna be AF for the rest of his life, or wait, and most of those patients will be cardioverted spontaneously. If not, you can delay and do your cardioversion in a delayed approach, or arrange for elective cardioversion as soon as possible. So this is three different options. Maybe we can take a minute to collect the votes from YouTube. I think because Ahmad Assam showed us in the first part that you can wait and the delayed cardioversion. So we're getting some answers for number two, and we're getting some answers also for number one, anticoagulation and rate control. So maybe you can explain to us.
Okay. So, of course, here we are faced with post-operative AF. Of course, prevention is much more better than treatment. So, in order to reduce the risk of post-operative AF, and this is a great concern in the guidelines that try to prevent it from occurrence, optimize hemodynamics, correct any electrolyte imbalance, especially the magnesium, identify the patient at risk of post-operative AF. If the patient is known to be cardiac, we can continue or initiate beta blockers if he is having cardiac surgery, but it is not a routine practice, and the guidelines was very clear in this. And of course, sometimes we can use amiodarone. If the drug prophylaxis was contraindicated, there is some consideration of something called posterior pericardiotomy or biatrial pacing, but it is not routine, of course, and no role for statins, bufa, digoxin, steroids, or calcium channel blocker as routine. And then post-operatively, of course, prevention is by optimizing the fluid balance, oxygenation, analgesics, trying to minimize inotropes and vasopressor supports, and continuing the prophylaxis if it was initiated before cardioversion, or sorry, before the surgery. But now we are having the post-operative AF. It is a real situation. If the patient is hemodynamically unstable, at the time I would go, of course, emergency cardioversion. It is clear. But the patient here is hemodynamically stable. He is just feeling some dyspnea and palpitation, but the patient is not having any sign of hemodynamic instability. So, of course, he would need to be anticoagulated, but after discussing with the surgeon in order to assess the surgical bleeding risk from the surgery. Then, after starting anticoagulation, I would assess is the patient is symptomatic. So at the time, I could go for rate control or rhythm control. If the patient is symptomatic and rate control is difficult, I can go for rhythm control. And if the patient, for example, is not very symptomatic, or I can achieve easily rate control, I can go for lenient rate control using beta blockers, calcium channel blockers, or digoxin. So here also choosing between rate and rhythm control depends on the symptoms and the feasibility of rate control. And then at discharge, I should assess the risk of long-term oral anticoagulation. There is nothing called that this patient, it was just post-operative AF, no need to put him on Charles-Vasquez score. No, nothing is called this. Post-operative AF, this means that the patient has a substrate for recurrence of atrial fibrillation, and so he should have assessment of the Charles-Vasquez score to start him in oral anticoagulation if he has at risk. So of course, don't forget to assess the long-term oral anticoagulation therapy in order to start him in oral anticoagulation if his Charles-Vasquez score is 1 or more in males, 2 or more in females. And beta blockers should not be used routinely to prevent postoperative atrial fibrillation if the patient is undergoing non-cardiac surgery. No rule for just routine beta blockers. So now let's answer the question. What I'm going to do? Will I go for just rate control or wait for delayed cardioversion or go for cardioversion directly? Here, of course, the patient is having atrial fibrillation of less than 12 hours. So here, it would be making sense that I can wait for delayed cardioversion because the AF is less than 12 hours. And also, the patient has Charles-Vasquez score here is 1 based on presence of peripheral arterial disease, which is a form of vasculopathy in the Charles-Vasquez score. So I can wait for delayed cardioversion, although maybe some other will go directly for cardioversion in order to restore sinus rhythm and trying to minimize the need for oral anticoagulation at the time being till the surgery passes in order to reduce the risk of bleeding from the surgery, but I can go for delayed cardioversion. Also, others may consider that just until we have the cardioversion or the spontaneous restoration of sinus rhythm, at that time I can go for rate control and starting oral anticoagulation. So what I can do here, I would combine the answer of waiting for delayed cardioversion, which I mean spontaneous cardioversion, till 24 hours. After 24 hours, I can go for cardioversion, and also I can arrange for rate control till I perform this. So here I cannot consider that it is just one clear answer from these. I think here maybe the most suitable answer is waiting for delayed cardioversion, but also rate control is maybe feasible if the patient is not very symptomatic, or the patient we can control his symptom with rate control. So let's summarize what you are going to do. I would start this patient on oral anticoagulation as soon as possible after discussing the bleeding risk with the surgeon. Parenteral anticoagulation would be better, and then if I choose oral anticoagulation, NOACs are much more preferred to VKA. Then regarding rhythm control, the patient is less than 12 hours, so I can wait for delayed cardioversion as he may spontaneously restore his sinus rhythm. And early cardioversion also is possible using electrical cardioversion, but less than 12 hours, I would suggest delayed wait for delayed cardioversion because he may restore sinus rhythm spontaneously. Then to maintain sinus rhythm, I can use here propafenone, flecainide, sotalol, unless there is evidence of structural heart disease, and we know from before their contraindication. Amiodarone can be used if there is structural heart disease in case that the previous medications are contraindicated. For example, the patient is having LV dysfunction or he is ischemic. Rate control till you restore sinus rhythm, of course, is feasible, and it can be the proposed strategy from the start using beta blockers, calcium channel blockers, or digoxin. And of course, echocardiography would be essential in this case to assess the LV function in order to decide whether calcium channel blockers can be used or not. And then when I discharge this patient, I should remember to assess his CHA2DS2-VASc score. Here, his score is 1 based on peripheral arterial disease, so it is class 2A to having lifelong oral anticoagulation. I know, of course, that many doctors refuse this, but the guidelines are clear. The patient needs to assess his thromboembolic risk in order to start lifelong oral anticoagulation. And of course, NOACs are the first choice, except in case of moderate or severe mitral stenosis or creatinine clearance less than 15 milliliters per minute in this case. So here this is the last case. So can we have any other questions or any any confusion regarding this case of the postoperative AF?
Yes, Sharif. Thank you so much. Again, we have a question to clarify the option of delayed cardioversion. My question is like this. What does delayed cardioversion mean? I think it needs waiting for 12 to 24 hours, if I got it correct, or there's a specific
Yeah, that's right,
definition for
Dr.
this.
Zahran, of course, yeah.
So it's waiting for 12 to 24 hours. Yes, and usually spontaneous cardioversion happens. And this is actually what we see in real life. Most of the times it's always like this.
I mean, you get up to 80% of the patients cardioverted spontaneously in the first 48 hours. So, I mean, it's
So you
very
just
common practice.
preserve or reduce the risk of stroke by administering anticoagulation, and you can wait. Yes. Thank you so much, Sharif. I think you may proceed now.
Okay, so at the end today, I have discussed 4 cases today, and we discussed cryptogenic stroke and the issue of having the AF as etiology and how can we investigate this. And we should not refuse a neurological consultation when he is asking us for ECG monitoring that the patient may having an embolic stroke due to hidden atrial fibrillation that we didn't document. We discussed AF with acute coronary syndrome and in case of CKD as well. And we understand the rules of the triple therapy and how in these guidelines they shorten the duration of the triple therapy to maximum 1 month. So this is a great difference in the guidelines this year. And what is the recommendation to reduce the dose based on the creatinine clearance in order not to refuse any NOAC because the patient just has CKD? No, it has a guidelines describing how to use a reduced dose and when it is contraindicated to use NOACs in case of CKD. We discussed AF in pregnancy, and we learned it today that rhythm control is still the preferred strategy in pregnancy, even if it is not mentioned clearly in the pocket guidelines, but it is explained in detail in the full text. Post-operative EF, of course, is very important to prevent from the start, but if it occurred, I should not refuse long-term oral anticoagulation just because it's post-operative. No, this patient still has a risk for lifelong thromboembolism. And also, I can wait for the delayed cardioversion in many of the cases if the duration is still less than 12 hours, up to 24 hours. After this, more than 24 hours, I can choose between rate control and rhythm control. Thank you very much for giving me this chance, Dr. Zahran, for explaining these guidelines. And for me, I have benefited a lot, of course, from this discussion and from explaining this lecture today.
Thanks a lot, Dr. Sharif. Actually, you made it very clear, very elegantly, and very smoothly through this very nice examples for case-based discussions regarding four very important the clinical scenarios that we actually see in our everyday life. Thank you, Dr. Sharif, consultant of electrophysiology and lecturer of cardiology at Ain Shams University. The first half was Dr. Ahmed Assam, consultant in cardiology at Worcester, UK. Ahmed actually showed us the guidelines, the definitions, and he wrapped up very elegantly the all guidelines for atrial fibrillation, focusing on the 2020 updates. And then he gave us a very nice clinical scenario for an old lady with atrial fibrillation and controlled medically to sinus rhythm, and then developed signs of toxicity from flecainide in the form of left bundle, and then how we modified the plan according to what jumps in our pathway. I would like to thank you both. All of our viewers on CEC YouTube channel are actually thanking you very much and wishing that you can attend with us in next session. So hopefully you can do that. Next Saturday, after 48 hours, we'll be discussing the updates in other congenital heart disease with Dr. Amira and a panel of elegant discussants with us. And next Thursday, we will be discussing the sports in cardiology, also the new guidelines 2020 with Dr. Yasser Alaa from Ain Shams and Dr. Hani Shahidi from National Heart Institute. And I would like to thank you all for staying late with us and for attending tonight and your valuable contribution. Thank you so much, Dr. Ahmed Ammar, and thank you so much, Dr. Sharif, and see you inshallah.